All right. Good morning, everyone. We'll get started here. Good morning. So today I'm going to talk about the Transpsoas approach to the lumbar spine, also known as the extreme lateral interbody fusion in some circles, hence the extreme spine surgery. So I have no disclosures. So first, I'm just going to briefly touch on the history of what usually you tend to see in the literature as the history of this approach. We'll talk about the pertinent anatomy, as this is pretty important for this approach and understanding the anatomy pretty well. We'll talk about many of the indications and contraindications, which tend to be up to the surgeon who decides to use this approach. We'll talk about the risks and benefits of lateral lumbar interbody fusion. I'm going to go through kind of in detail the steps of how you actually do this approach and the procedure. And then throughout the talk, I'll bring up some current literature articles. So usually speaking, most people talk about in 1998, there was a Dr. Rosenthal in Frankfurt, Germany, who was doing endoscopic thoracic lateral access approaches. In the top right-hand corner is a gentleman, Luis Pimenta. In 1997, Luis Pimenta was training in Gainesville, where he was doing a fellowship in spinal endoscopic surgery. And then after that, in 1998, he underwent a fellowship with Dr. Daniel Rosenthal in Frankfurt, Germany, where then he ultimately returned to Brazil and started really working on developing the lateral approach. In 2001, Luis Pimenta published on this in a paper and described the lateral transpsoas retroperitoneal approach for lumbar interbody fusion. A similar paper was published in 2003 by Bertignolli. And as these papers were being published, the Americans kind of caught on to this and started figuring out how to bring this to market, how to design products. So they really started getting involved with designing the retractors, neuromonitoring, et cetera. And then ultimately in 2006, Dr. Osger published a paper out of UC Irvine, really kind of talking about today what we call the XLIF. And he did this in association with Luis Pimenta. So in that paper, they talk about, again, a lateral retroperitoneal transpsoas approach with the goal of being able to access the disc space anteriorly and be able to perform complete discectomies, distraction through the disc space, and placement of interbody fusion. And the whole goal was that you could do this procedure without an approach surgeon compared to an anterior approach. Generally, most spine guys are using an approach surgeon. With this technique, the goal is that you don't have to do that. And the reason why through this approach is that you can hopefully reduce the approach-related morbidity associated with anterior approaches, primarily the risk of vascular injury. And then the other reason as well, instead of going posterior, the goal is you don't have to disrupt a lot of the posterior soft tissues that we do when we do direct decompressions. So some of the nomenclature, which I thought was confusing, especially when I was in medical school learning about this, what do all these acronyms mean? The one you primarily hear of is the XLIF for extreme lateral interbody fusion. This is more of a marketed name with a specific company, but you also may hear direct lateral or lateral lumbar interbody fusion. And again, this is the transpsoas retroperitoneal approach. Another approach similar to this is the OLIF or oblique lateral interbody fusion. And then this approach is also retroperitoneal, but instead of being transpsoas, you go right around the front anterior to the psoas. And then a common one, which many people are familiar with, is the ALIF or the anterior lumbar interbody fusion. And this can be done either transabdominally or more commonly retroperitoneal. So why do this? One, a lot of times when we talk about lateral approaches, the idea is through this phenomenon called indirect decompression. We don't have to go directly through the posterior elements to try and decompress the spine. We can do this by an indirect means through the front and increase foraminal openings in the central disc or the central canal space. Again, instead of going posteriorly, this approach causes less tissue trauma and less wound issues. This has been shown in different studies. As well, the idea here, since you're not going through the front or the back, you avoid disruption of the posterior and anterior longitudinal ligaments, ultimately leading to maybe a more stable construct. Many studies published kind of perioperative outcomes showing less EBL, shorter OR times, as well as shorter hospital stays in comparison to posterior fusions. Going through the side, kind of similar to the front, you're also able to place a larger cage. And in doing so, you can argue that you can have increased lordosis and increased disc height, which you may not be able to achieve through a posterior approach. As well, there's some articles that talk about maybe there's less subsidence than doing transforaminal lumbar interbody fusions. Again, the idea here is that it's a more biomechanically stable construct. You're able to put in a larger cage with a larger footprint, and especially with a lateral approach, you can get these cages over top of the peripheral cortical bone, which is going to be stronger than your inner end plates, where generally your T-lift cage sits. This is a described technique for correction of many different adult spinal deformities, reduction of spondies, coronal deformities, and sagittal deformities. So here's a kind of a cross section, which I thought was interesting to kind of demonstrate the different sizes and cages which you can place through each approach. You see there in the green, that's the transforaminal cages, which are much smaller than generally we're able to place with an A-lift cage or an X-lift cage. Ultimately, the X-lift cage does have the biggest cross-sectional surface area overlying that end plate. So, like most things in life, does bigger, better, does size really matter? So a couple of studies kind of look at this and describe the cross-sectional area of the end plates as being an important factor for interbody grafts and interbody fusions, because ultimately you're increasing the surface area for which fusion can occur. You're able to get greater discectomies and end plate preps than you can do more commonly through a posterior approach. And through this, again, you can get larger cages, larger correction, and ideally less risk of subsidence. A study in 2014 looked at actually a cadaveric study looking at disc space preps versus X-lift versus A-lift. They actually found that X-lifts have better disc space preparation at 3, 4, and 2, 3 versus an A-lift. But overall, A-lifts and X-lifts have superior end plate preparation as compared to posterior fusions, because obviously you don't have to retract the dura and you have a greater access to disc space. So some more arguments for kind of why to do this. Posteriorly, you're going to encounter the dura. You're not going to encounter the dura during this approach. So ideally, you should not be exposing any thecal sac or nerve roots. So the risk of CSF leak is basically negligible. Lower rates of sympathetic dysfunction. Doing anterior approaches in the literature, it's been described that this is as high as anywhere from 9 to 43%. The lateral approach reduces that risk, which you would be subjected to anteriorly. Again, another reason, you don't have to mobilize the great vessels through this approach. The literature says that anywhere from 0 to 18% of vascular complications with the A-lift, most commonly at L4-5, either at or right below the bifurcation of the vessels. And most commonly, the complications you tend to see are either DVTs or vessel retraction injuries. As you retract the vessels away, you can get these kind of shearing tears. So some people actually talk about ligating the iliolumbar vein prophylactically, especially if you're going anterior, to try and decrease that risk. And then a significant, although low risk with anterior approach, is the risk of retrograde ejaculation. It's primarily a contraindication in younger males. So this was another technique described that you can still go through kind of a somewhat anterior approach with reducing that risk in a patient population that may be at risk. So I thought this was kind of a good slide to show exactly what indirect decompression is and what we had tried to achieve. So here you can see kind of a lumbar interololisthesis with foraminal narrowing as well as disc space collapse. And then after placement of the cage, you kind of see somewhat a decent reduction of that spondylolisthesis, as well as the increase in disc height and foraminal opening. So indirect decompression, what does the literature show? Kepler published a study that through X-lifts, they noted that they could increase the foraminal area up to 35%. Study in 2007, kind of at the forefront of when the lateral approach was getting started. They looked at foraminal height increases in the A-lift versus the T-lift. Overall, the A-lift showed about a 2.7 millimeter increase versus the T-lift was actually slightly negative in their averages. And then in 2014, in kind of a comparison study, X-lifts at 145 patients found an average foraminal height increase of 2.5, which was similar to what was being achieved through the anterior approach. And again, kind of one of the ways that this happens is because you're preserving the ALL and PLL, when you put in that cage, you can kind of get a reduction of the vertebral bodies through ligament metaxas, which ultimately can help lead to the decrease in central stenosis. So some of the people out there think that central stenosis is a contraindication to lateral interbody fusions and indirect decompression. So here was actually a recent study published in the Journal of Neurosurgery in 2020, looking at central stenosis and kind of what happened pre-op and post-op when doing an XLIF. So this was a retrospective case series from one institution. They looked at 42 patients with severe degenerative lumbar stenosis, wasn't just mild or moderate. And they did pre-op and post-operative MRIs. Ultimately, these patients either had L3 or 3, 4, or 4, 5 levels operated on, and all these patients underwent posterior fixation without direct decompression. And so the main thing they looked at was a cross-sectional area of the thecal sac. Preoperatively, they averaged about 55 millimeters, and then at last follow-up, that almost tripled to 132 millimeters. The other thing they noted was their fusion rates at 1 year were 89%, which is pretty good. And then overall, the disc height increased from 6.3 to 9.6 millimeters. So this study kind of did demonstrate really that you can get pretty good indirect decompression with central stenosis. Here is kind of an MRI that they showed from their study, which I thought depicted that pretty well. You can see there on the pre-op films, there's an anaerolisthesis as well as significant central stenosis. And then 3 weeks post-op and last follow-up, you can see a pretty significant correction of that spondylolisthesis as well as decompression of that central stenosis. So another thing to talk about is segmental lordosis. So usually, people that do deformity think, going through the front is obviously considered superior because you can do an ALL resection, you can release that anterior longitudinal ligament and then put in a pretty big cage to try and get a decent lordotic correction. Overall, a study in 2014 looking at this, they found that on average per level, A lifts get you about 4.5 degrees versus X lifts get you 2.2 degrees, so slightly less. A couple of other studies looking at just X lifts, they averaged anywhere from 2.4 to 2.9 degrees of segmental lordotic correction. And then the study in 2013 just showed that most significant improvement in lordosis was at the 4 or 5 levels, which most commonly is near the apices of the lumbar curve. And then lastly, there was a direct comparison in 2014 in spine that looked at A-lift versus X-lift, and again, kind of redemonstrated that you can get a little bit better segmental lordosis correction with an anterior cage versus a lateral cage. But, 2 degrees, is that a lot? Does that matter? A couple of studies kind of pushed the envelope to see what more we could do. So Uribe published in 2014, once we started developing hyperlordotic cages and expandable cages, obviously we could try to achieve more correction. So he used hyperlordotic cages of 20 and 30 degrees in combination with an ALL release through the lateral approach, and found that he could improve on average 7 and 11 degrees of segmental lordosis, respectively, to those cages. In 2012, another series of 7 patients, again with hyperlordotic cage, they found that with an ALL release, they could achieve up to 17 degrees of lordosis. And then in 2014, another paper found actually up to 23s of lordotic correction. There is some confounders in this paper, though, where some of these patients ultimately did end up going posterior osteotomies to try and increase their lordosis. So kind of a conclusion in regards to that, I would say on average, it seems most of the papers are showing you can get plus or minus 2 degrees of segmental lordosis correction through the lateral approach and mostly these fixed cages. If you start to get into the realm of expandables and hyperlordotics, including an ALL release, and then if you really want to do some sort of posterior osteotomy, you can get pretty significant correction up to 20 degrees at each level. The goal here is, again, this gives you another option instead of going front back, that you can do this through a lateral and posterior approach instead. And again, although A-lifts is usually considered the gold standard for kind of getting in that big cage for correction, you can still get pretty significant correction through a lateral approach. So what are some of the indications? They're kind of everywhere. The more you start looking, generally speaking, in the lumbar spine, you have access to the L1 to L5 disc spaces. You're generally blocked by the 12th rib and the iliac crest. At 5-1, your iliac crest is usually too high for your lateral access. So that's a level that you're most likely going to have to do an anterior approach. And then, like I've talked about, you can use this in deformity. Another indication people will do this for is if they've had previous posterior surgery where the dura has been exposed or a previous dural leak. This is another option where you don't have to go into the back and have that risk of another dural tear. And then again, here's just a bunch of different papers showing all different types of indications. You can find an indication for almost anything if you really look hard enough. I thought an interesting one, I don't think there's any products on the market, but people have looked into, and they may still be trying to do total disc replacements from the lateral approach. So what are some of the contraindications? Again, pathology at 5-1, you're going to be blocked by the iliac crest, as well as the lumbar plexus courses more anteriorly at this level. Even some patients with that Mickey Mouse pelvis can even be blocked at 4-5. So you need to look at your pre-op films and study those. Another thing that can be a contraindication is some people are doing standalone cages. You need to be careful when doing those, especially if it's at a level of high biomechanical stress, patients that are osteoporotic, and again, at a level where they have some sort of fusion above or below, maybe it's an idiopathic fusion, as well as if it's a high-grade spondy, then they're going to be somewhat unstable. So standalone cage is probably not your best choice. Things you need to talk to your patients about preoperatively. Have they had any sort of retroperitoneal surgery in the past? Have they ever had any sort of retroperitoneal trauma or infection? That may be something that may steer you away from this. You need to really look at their vascular anatomy, make sure they don't have any aberrant vessels. Look at the psoas musculature. Large psoas may sometimes preclude you from being able to get to that safe access point. Patients with significant stenosis, a lot of people still think this is a contraindication, especially if you have facet hypertrophy or significant ligamentum hypertrophy, because ultimately, even through indirect decompression, you're not going to be able to decrease the size of the facets and that significant ligamentum hypertrophy. The MRI up in the top right-hand corner is what we would call kind of an anterior psoas. This can also be a general contraindication as it places you at a higher risk for femoral nerve injuries intraoperatively. So you'll see that the psoas muscle kind of rises away from the vertebral body ventrally and laterally. And it congruently kind of stretches the lumbar plexus. So it puts it at a little bit greater risk when you start to see that on your MRI. Another contraindication sometimes can be osteoporosis, especially through the lateral approach, depending upon what you're doing with your cage, previous abdominal surgery, and then any sort of, again, idiopathic fusion or locked facets in the back. You're not going to be able to achieve a correction through the front if you have that kind of posterior fusion back there. So preoperative planning is very essential for this procedure. You need to really study your films. You want to look at the psoas size and location. You want to see where your great vessels are or any other aberrant anatomy near your approach. Rib positioning. So at your superior levels, in general, you're going to run into that 12th rib. If that's a problem, sometimes you can do an intercostal approach, or you can resect the rib to achieve your access to that disc space. Height of the iliac crest we talked about, but just make sure to look on your films to try and see your trajectory if that's going to be a problem for you. They actually now have some angled inserters for these levels to improve your access if you can't go directly, so you can kind of go at an angled approach. Scoliosis, just something to keep in mind. If you are going lateral in the concavity, you're going to obviously have a much deeper working distance down to the spine. One caveat is you can do this if you're doing multiple levels on a concavity, you may be able to reach them all through one incision. Versus a convexity, you're going to approach your anatomy pretty quick as it's going to be much closer to you on your approach. And then another thing to keep in mind is that the lumbar plexus generally runs more anterior on a concavity. If you are going above kind of L2 to L1, then you may start getting into a transdiaphragmatic approach. So if that's something you're not comfortable with, you may need to get thoracic surgery involved. Positioning is pretty important. So in general, this started out as a lateral decubitus position. You basically put the hip over a break point of the table. You want to make sure there's padding underneath the perineal nerve. The top leg should be flexed at the knee and the hip so that you can relax that psoas and take tension off of it. And then ultimately you place your axe roll and then a pillow between the knees. So there's studies out there. Originally, people started talking about breaking the bed to try and increase the working space between the ribs and the crest. You need to be careful doing this because you can cause traction neuropraxias from prolonged traction. There are some people that are actually going away from this altogether and doing no break in the bed. Next thing too, which I put on there, is position of the C-arm. So basically you want to position the patient so that you can obtain a true AP and lateral fluoroscopic image, which you're going to be using basically throughout the entire case. So once you have the patient positioned, you're going to rotate the bed so that direct lateral is 0 degrees on the C-arm. And that way you're going to be operating directly perpendicular to the floor. The reason for this is it's going to help you increase your safety by not having to change your trajectory. You can always basically aim straight down to the floor when accessing your disc space. Obviously, you know, because if you start to go into anterior, you have the great vessels. If you go posterior, then you can end up in the contralateral side neural foramen. Another tip when performing at multiple levels, make sure you readjust the rotation of the bed at each level to, again, achieve that perfect lateral. And then most importantly, make sure the patient's taped down well so there's no movement during the case that can throw you off. I'm not going to go into great detail, but there's been the new discussion where people are now doing prone laterals. So they're doing the lateral approach through a prone positioning. And kind of the reason for this is if you want to do posterior instrumentation, if you're doing a lateral approach, a lot of times you're going to have to reprep and redrape and reposition the patient to then go posterior to put in your pedicle screws. There are some patients that are some people that are doing pedicle screw placement in the lateral position. I have not seen it, but it sounds somewhat difficult. And it seems like a lot of times if they're doing that, they're doing it under navigation. But through this approach, you can do kind of both your posterior and lateral access all in one position as well. Some people argue you can get better lordotic correction through this just by the positioning of the patient on the table. So what are the radiographic views you're going to look for? Here, basically a somewhat perfect AP and lateral of the lumbar spine. On the lateral, you want to make sure your end plates are pretty cleaned up and overlying each other. Your pedicle should be superimposed so that you only see one pedicle. And then on the AP, you want your spinous processes at each level midline. And then you should basically be able to draw a transverse section through the pedicles straight across, and that they should be equal bilaterally. There, I put up a picture of kind of some different skin markings that people have done. The top one, I'd see, have not really seen anyone do, which is basically drawing out your vertebral bodies under X-ray. The bottom ones are different types of incision finders, which I'll go through one of those next, but that can just help you kind of localize your disc space for where you're going to make your incision. This is the finder that I have seen and used. Basically, it's a cross, and you lay it on the patient in a lateral position, and you're going to draw out your anterior and posterior borders of your vertebral body. And then you want to place that X basically between the anterior 2/3 and the posterior 1/3 of that disc space. After doing this, then you're going to make a skin incision that's generally only about 2.5 to 3 centimeters in length. And you're going to localize it directly over the disc space. Single incision can be used for multiple levels. If you're doing multiple levels, you can cheat it up or down more towards the midpoint between the levels if needed. And again, that ideal target, generally speaking, which I'll go into further, is the between the anterior 2/3 and the posterior 1/3 of that disc space. So the approach, a lot of people now are doing this more through kind of like a minimally invasive blunt feel technique. You can do it through like a true open or a mini open if you want to. But generally speaking, you're going to do blunt dissection down through your abdominal musculature. This is going to be a muscle splitting technique. You're going to encounter your external oblique, your internal oblique, and then your transverse abdominis muscles. And then you're going to split them along their respective fibers. Once you go through this, you're ultimately going to be into the retroperitoneal space. Once entering, you're under direct visualization. If you're doing open or through blunt feel, you're going to do gentle sweeping motions with your finger to release adhesions between the peritoneum anteriorly and the psoas and abdominal wall. And then ultimately, you're going to be able to palpate the psoas lateral to the vertebral body. And then you can kind of verify your positioning and disc space from there. The psoas fibers generally are split along the direction of their axis. And then ultimately after that, you'll be down to the underlying disc space. Once you get to that disc space, then you're ultimately going to take, it's kind of like a trocar, and you're going to verify your start point with that going through the psoas. If a different level must be operated on, a new dissection of the psoas should be performed. So make sure you take your retractors all the way out. You don't slide them up or down throughout the psoas. And then ultimately, as well as you can see kind of with the anatomy, depending upon how superior, inferior are, you have some of those retroperitoneal structures like the kidney that you may be feeling on your approach. So neuromonitoring is pretty important. So over here on the left as a lateral and AP of the lumbar spine, and this is kind of the initial dilator that you're going to place. And again, you want to position between that kind of anterior 2/3 and posterior 1/3, and you want it directly perpendicular with your disc space in the floor, kind of directly down to that. Over the years, a lot of people have developed kind of try to develop safer techniques to doing this approach. So a lot of these now are neuromonitoring probes. So as you're going through the psoas, you can actually turn it 360 degrees and obtain different neuromonitoring values to have an idea how close or far away you are from the nerves. So once you get that down there and you feel it's in a safe position, you're ultimately going to hit it into the disc space. And then over that, you'll start doing serial dilations for then which you'll be able to place your retractors. Again, neuromonitoring is important. You should probably be doing, your transcranials, your SSEPs and stuff like that, but ultimately it's going to be up to the surgeon on what they want to do. Another thing to consider is monitoring the saphenous nerve to try and detect femoral traction injuries while doing your surgery. So here's a picture. Once you place those serial dilators, that retractor goes down over it and you're going to reach the disc space. Once you feel it is an appropriate position, there is a posterior shim that kind of goes down along and then wedges into the disc space to hold your retractors in place. And then you're slowly going to open up kind of those retractors to an appropriate position to allow you to visualize the disc space. And again, through every step in this, through dilation and placement of your retractors, as well as once you start to open your retractors, keep watching your neuromonitoring to evaluate for the nerves. So once you're down, here's kind of a step-by-step progression through the case. You're going to start with an annulotomy with a 10 blade, followed by a discectomy. And you can use your pituitary rongeur or whatever tool you like best to remove the disc material. And then through some gentle distraction, you can put your cob in there. You're going to get your clean end plates. And then ultimately, it's important as well. You want to go through the contralateral side and release a contralateral annulus carefully all the way across the disc space. So once you have your good end plate prep, all the end plate cartilage is off, you can start trialing, which you see in the kind of bottom pictures. And then ultimately, you'll be able to trial and place your implant. After implant insertion, double check your position on your APN lateral. And then ultimately, this is an important part too, is you want to have good fascial closure to try and prevent any sort of post-op hernias at the surgical site, since you are going through that abdominal musculature. If this does happen, then you may want to get some general surgery colleagues involved. So talking about the lumbar anatomy here, kind of going back through the approach and what's important. We'll spend a decent amount of time just kind of going through this because it's important to knowing what's going on when you're going down. So the lumbar plexus, complex neural network formed by the ventral branches of the first to the fourth upper lumbar nerves. It has 7 major branches that pass through the psoas major and ultimately run obliquely down through the pelvis. Sorry, the intrapsoas part of the plexus is what is at risk during a transpsoas approach. the last thoracic nerve, or T12, usually supplements the first lumbar nerve, in which forms the iliohypogastric nerve, which you see there, as well as the ilioinguinal nerve. These are important on your superficial dissection, and they supply sensation to the buttock and hypogastric regions, and the ilioinguinal nerve supplies sensation to the groin and external genitalia. These two sensory branches can be commonly injured during the blunt dissection of the oblique muscles. Generally, that's why we do blunt dissection, and we do not use bovie once we go through the skin during this approach. L2, 3, and 4 form the LFCN and obviously supply sensation over the lateral thigh, as well as the femoral nerve and obturator nerve at these levels. The femoral nerve supplying hip flexors and knee extensors, while the obturator supplies the adductors of the leg. And then these branches are more at risk during the dissection of the psoas. This can occur, injuries can occur via either direct trauma or indirect trauma by retraction, causing ischemia. And it's a side effect that we'll talk about too, kind of throughout the rest of this presentation. But special attention should be paid to the genital femoral nerve. This is the only nerve that is going to be anterior to where you're going to dock your trocar. And it's formed by the union of the axons of L1 and 2 and supplies sensation to the upper anterior thigh, as well as the anterior scrotum in males and the mons pubis in females. So it's really the only ventral nerve. So just be aware where that is. So there is a danger anteriorly to where you'll be as well. And then you can kind of see there, thought those were some of the better anatomy pictures, really showing you this is somewhat of a danger zone if you stray too far from where you need to be. Again, pre-op imaging, when looking at your psoas, so you'll see here, I talk about you want to be kind of at that anterior 2/3 of the posterior 1/3 of that disc space. This changes as you go inferior and move down in the lower lumbar spine. And I show you kind of a cross section here at each level so that you can really see that as you go inferior, the psoas starts to move anteriorly, which is part of the reason why you're going to slightly change your start points. So there was a study in 2010 that Uribe published, and it was a cadaveric study, which kind of helps us see where we should go with this. So the safe working zones for the Transpsoas approach, you basically divide the vertebral body into 4 quartiles in the sagittal plane. And then through this, we can kind of see here what I talked about. For your start point, generally speaking, you're going to be in zone 2 for your 2, 3, and 3, 4 disc spaces. And as you go more inferior, you're going to start to cheat that a little more anterior. And that's because the lumbar plexus starts to move anterior. And so you're going to be at a slightly increased risk as you go inferior of damaging any sort of nerves. The other thing to consider again is your great vessels down there. Generally speaking, they shouldn't be too involved with this approach. It's more concerned with the anterior approach. As well, when you're in the lateral decubitus position, the aorta and the IVC tend to fall more anterior to the surgical corridor in this position, which increases your safe zone. As well, that's why, generally speaking, through a lateral approach, vascular injuries are almost none to very rare. You just, again, need to be careful of your retractor placement and make sure during your disc space prep, et cetera, that you're not migrating too far anteriorly. And then again, kind of retroperitoneal structures to be mindful of. You're going to be working near the kidney, the ureters, and the adrenal glands. And again, just another anatomy depiction of kind of showing you where those are, because those are technically at risk during this approach. It's a very low risk that any of these are generally injured. So now you placed your cage, everything's done. Great, now what? So after all that, did you even get a fusion? So looking at fusion rates through the lateral approach, generally speaking, they're all very similar to both the anterior and posterior approach cages. 2015, a study of 77 patients found a 98% fusion rate, which was extremely high. I listed kind of the bone graft substitutes as well as whatever they placed in a cage in these studies, just for your info. But overall, the fusion rates with the lateral approach is pretty similar. One study showed 93%, and then another study showed 85%. So some of the things too, so once you place your cage, you need to have additional augments. There are screws that can be inserted through the cage. There are plates that you can also add additionally around the cage, and that you place screws into the vertebral body, as well as whether or not you want to add posterior fixation to supplement the construct. There are people that are doing standalone cages. People have different indications for who those people are. Generally speaking, I would say it seems like the patients that may benefit and be okay with a standalone cage are young patients, good bone stock, and minor deformity. Some studies have published on revision rates of standalone cages and found anywhere from 3.5% to 13.5%. Obviously, this is going to be patient dependent on who's included in these studies. But overall, these studies found that failure is generally associated with significant deformity, greater than a grade 1 spondylolisthesis, osteoporosis. And what happens is generally these patients end up getting graft subsidence, loss of decompression, and then ultimately that indirect decompression fails. So then generally you have to go posterior. So, if you have any concern at all, you might as well just add some sort of, you can do percutaneous pedicle screws or some sort of posterior support to increase the stability of your construct. Interestingly too, the flip side, there was some things I read from Luis Pimenta and Juan Uribe. So overall, they generally put posterior fixation in almost all their patients. They say at this point in their career, for the 20, 30 years they've been doing it, less than 10% of the patients get standalone cages. But they said one of the patients they consider them in is patients that are high risk, anticoagulated, you don't want to go posterior, et cetera. This is an additional option that you can get in and out relatively quickly with low blood loss as an alternative. So how do we increase effectiveness of standalone cages? Use as wide of a footprint as you can to get that good cortical surface contact, as well as a peripheral cortical bone. You don't want to overstuff the disc space. Make sure you're respecting your end plates when you're doing your disc space prep, all general things that we always talk about. One of the side effects here, which I found interesting, so using these cages with the plate and screw construct, you basically put a screw above and below the level you're operating on, and then you can get these actual coronal plane fractures, which have been described in the literature. Juan Uribe talks about this. He actually no longer uses this anymore. And he said industry tends to push these on a lot of surgeons because they say, oh, it increases your construct stability and stuff like that. It's an additional CPT code. But it is a risk with this plate. And so a lot of people have actually started to go away from this. And the idea of how this fails is one of two things. One, you are putting screws directly above and below that cage. So you're increasing the stress concentration kind of right at that area of the end plate. And then two, if you get any sort of graft subsidence, these are basically a fixed angle construct. So that's going to basically saw through your vertebral bodies if it migrates. So overall, what do the outcomes look like? Generally speaking, across most of the literature, patients have improved, ODIs, patient-reported outcomes, et cetera. When looking at deformity cases, this one study showed that they had an average coronal deformity correction of 25 down to 13.5 degrees. And then overall, it seems like most patients have comparable satisfaction rates through the lateral approach. So what are the downsides? One, which is, again, a lot of these risk factors you need to bring up to the patient, especially transient hip flexor weakness. Since you are violating the psoas through this approach, it's very common that you're going to have hip flexor weakness post-op. And as you go more inferior, generally think this rate may increase based on the course of the plexus. Overall, though, patients should know that most all this resolves by 6 months. And generally, it's thought to be due to either edema, hematoma during your surgical exposure, muscle trauma, or stretch from the retractors. And some ways to try and hopefully decrease this is one, when you place your probe doing your intramuscular dissection, you have that neuromonitoring to try and evaluate where your probe is in relation to the nerves. You want to place your retractors at the appropriate position for the level, which I talked about, kind of what level you're at, depending upon where the psoas is. And then ultimately, you want to limit your retraction time to less than 30 minutes per level, which I'll touch on the next slide. Ultimately, there are permanent motor complications that can happen from this approach. A meta-analysis in 2015 found on average, most studies saying anywhere from 2.9 to 4.6%. These are generally related to retraction time greater than 30 minutes. It's much less frequent that patients developed a direct nerve injury through this approach. And overall, a 12-month follow-up, they found across all studies, on average, 2.9% of patients experienced persistent motor deficits, most commonly quad weakness. End plate fracture can happen, as well as, these are very, very rare, but you are going to be retroperitoneal. So things like urologic injury, bowel injury, et cetera, are considered a risk through this approach. And then another thing to discuss is pseudo hernias. Very rare, but it can happen. And usually this is basically traction on the ilioinguinal or iliohypogastric nerves, or nerves innervating your kind of abdominal musculature. Generally speaking, this tends to be transient, although it can happen. Nerve retractor timing and placement. As this was developed, we realized the importance of this as trying to minimize risks associated with this approach. So generally speaking, you want to limit your retractor timing for about 20 to 30 minutes. So you can start a timer in the room, et cetera. So you kind of have an idea how long you've been in there when you're doing this. 2015 study looked at this, and they found that in this paper, retraction time less than 20 minutes, there was 0 lumbar plexopathies, and again, advocated for retraction time less than 20 to 30 minutes. Uribe published his study in 2015 looking at this, and he looked at over 300 patients undergoing surgery at 4.5. Again, 31% had IP weakness, 13% had sensory dysfunction, and 4.5% had motor dysfunction, most commonly the quad. He looked at different variables in regards to retractor placement, timing, neuromonitoring, et cetera. He really found no difference in regards to the initial posterior blade reading. So once you put your blades down and you open your retractors, there was really no correlation in what the neuromonitoring was reading with the eventual outcome of having any sort of neurologic side effect. The biggest thing, again, he also noticed, which reinforces the idea of retractor timing, is a positive relationship between symptomatic neuropraxia and total retraction time. And in his study, on average, patients that experienced symptomatic neuropraxia had a retraction time of over 32 minutes versus 22.6 minutes. And again, you want to retract that nerve from anterior to posterior. You never want to retract it from posterior to anterior. And another thing, a lot of times we have a habit of opening retractors bigger. You only want to open them as much as you need to really kind of identify that disc space to do your work. The anterior thigh sensory deficit is somewhat common. Up to 40% of patients in one of the studies had this post-op, but basically it continually always resolves at around 2 weeks, and it's just kind of a retraction neuropraxia. I talked about, again, the iliohypogastric and ilioinguinal nerves. When you're doing your superficial dissection, you don't want to use bovie, you want to use blunt dissection. Autonomic injuries for this approach are generally pretty rare, and that's one of the pros for this approach versus anterior approach. So things like dysfunction of the viscera or sexual organs that you're more concerned about with an anterior approach are going to be pretty limited through this. And then vascular injuries, there are documented reports of this. Obviously, if you start to migrate too anteriorly with your instruments, but overall, there was a study there by Rogers that showed out of 600 patients, there was no vascular, no visceral injuries. Long-term risks, the feared complication long-term is implant subsidence and loss of your indirect decompression. You can get lateral migration of the cages, which can cause leg pain if they start to migrate towards the neural foramen and cause exiting nerve root impingement. A study by Lee looked at subsidence rates. He found overall radiographic subsidence in his cohort was about 14%, although only 2% of these had any sort of clinical outcome with their subsidence. So overall, even if you do get some subsidence, most patients didn't have any sort of clinical problem with that. And again, some of the tips to try and decrease this: avoid over distraction of the disc space, protect your end plates. And then some studies and people talk about getting DEXA scans on these patients preoperatively and trying to treat them or tee them up a little bit before you do their surgery. And then another risk, obviously, is pseudoarthrosis if you don't get a good fusion. So obviously, with this approach, a lot of people were concerned with the risk of nerve injuries and stuff like that. So they said, instead of going through the psoas, why not go through the front? So that's when the OLIF was developed, and people that are more advocates of that basically say you don't have to worry as much about that neurologic risk just going around the front of the psoas. So 2019 study published in the Journal of Neurosurgery by Uribe and a bunch of his residents at the Barrow Institute. They did a systematic review and meta-analysis comparing the XLIF versus the OLIF approaches, and overall had pretty similar rates of complications, although the complications which they had slightly differed. The OLIF obviously had higher rates of vascular complications and trade-off for higher rates of neurologic complications with the XLIF. And I highlighted here kind of those differences between the two approaches. The XLIF had higher levels of transient thigh pain and numbness at 21% and 19% transient IP weakness, which is kind of somewhat similar to the other numbers I've shown. Permanent motor deficits across this was 2.8% in the XLIF group, which was similar to what I presented before. But the OLIF group is not without its own complications. It still had a 1% permanent motor deficit through this approach, even though you're going anterior to the psoas. There was 0 sympathetic plexus injuries in the XLIF group versus as you start going more anteriorly, you're going to be closer to that plexus. So the OLIF actually had 5.4%. And then looking at the vascular injuries, OLIF had 1.8% in comparison to 0.4 in the XLIF. So overall, similar complication rates. It's kind of up to you as a surgeon what you feel more comfortable with, and it's a trade-off between whether or not you want to deal with a higher vascular complication rate versus maybe more of a transient neuropraxia. So in conclusion, you are limited generally at the 5-1 disc space. Generally, L1 through L4 are your more utilized levels. As you start to go inferiorly, the idea is that your lumbar plexus is going to be more anteriorly, so you may have an increased neurologic risk, most significantly in 4-5. With the understanding of anatomy and retraction time, our use of neuromonitoring, hopefully we kind of continue to decrease our risks over time. And it's important to advise these patients preoperatively, if you're going to do this approach, that they should be aware that it's likely once they come out of surgery, they're going to have probably thigh numbness and hip flexor weakness. But generally speaking, this usually resolves. This is a good approach that kind of respects the soft tissues instead of going in the back. And it's obviously a quicker procedure for those that do it, more often, and be able to fit, bigger cages, bigger footprints in. I think it's, a good approach for the right patients with the correct pathology. If you have significant facet hypertrophy or ligamentum hypertrophy, you'd be concerned that if you're just going from the front, you may not be able to obtain the sort of decompression that you're going to be able to achieve through the back. So while there's no ideal technique for every case and every patient, obviously evaluating the clinical presentation and radiographic pathology and the anatomy, I think there's patients that, may be appropriate for this technique. And then I will include our celebrity in the stands here, who gave me a call. So Dr. Malberg was doing this back when it began to start, and wrote a chapter on the lateral approach. So nice to hear from you about this. I wasn't able to get access to the book, but I found your name crawling around some places. So I'm sure maybe you can include some information for us from your experience too. So. Yeah.
There we go. There were no cages, so the approach was for an interbody fusion, and with bone graft material, we used iliac crest bone graft, tried the demineralized bone matrix. That was not terribly satisfactory by itself. And to supplement it, we did transfacet screws percutaneously. So it was done prone. We went not extreme, we called it extreme lateral, but it wasn't 90 degrees. It was on average about 70, 75 degrees. It's Transpsoas. In the first two cases, we had transient anterior thigh numbness. And we changed the trajectory a little bit, took it a little bit more lateral, and we didn't have any more cases of those. The original system was purely dilators. And I stopped using that system when the engineers start dilators. And didn't let me know, having done the first case for them, I was a little disappointed that they decided to make changes without even asking. So we had a case where we had motor weakness, and it was fortunately transient. But when I was doing this serial dilating, they had decided in the upper numbers, rather than going sequentially a millimeter at a time, they decided to skip some millimeters. So we went from 10 to 12 to 15, and kind of got me a little bit upset. So I moved away from that, and I didn't go back to extreme lateral until a number of years later when we had the retractor, the expandable retractor, with the system that you showed. Doing the totally retroperitoneal approach, 90 degrees. I did jack the table almost all of the time. And one of the upper ones, we did need to do a rib resection. And back when I trained, when you had a couple of years of general surgery, I didn't bother asking a thoracic surgeon to remove part of the 12th rib. It's really extra thoracic, and it was just another piece of bone in the way. And if you're doing that, it makes nice bone graft. So overall, it's a very good technique. It was started initially for mechanical discogenic pain rather than decompression, because we didn't have any way to expand the space. And I think the ability to do foraminal decompression with the cages is quite satisfactory. But in the right patients here, it's all patient selection that does this. When we were originally doing the facet screws, that works pretty well as an adjunct for a cage. And with the Nuvasive cages, they have the side plate that you can attach to the cage with the screws that you showed. We didn't have any problem with breakage, but one of the things you have to be mindful of with those screws is the X-ray that you showed is the screws were parallel to the end plate and parallel to the cage. And that's where you get into trouble. Screws should diverge. Aim on the upper one up and out, and the lower one down and out. And that will help you avoid the stresses on the end plate that can lead to that kind of fracture. But if you're concerned about that, then supplementing with facet fixation, rather than it's much easier to do than pedicle screws, especially if you got the patient in the lateral position. Originally, we had quite an elaborate guidance system for those, and it would take us an additional 40 minutes to put in a couple of facet screws. And after the third case, I abandoned that and just freehanded it using the fluoroscope. And then you can do it in like 10 minutes, and it makes a good supplement. So overall, it's a good approach. I think it's underutilized. And rather than stretching the size of the cages, you want to stretch the envelope. We ought to stretch the envelope for the indications for it. A lot of patients who have claudication or symptoms of uh, compression do get significant enough relief with this approach to avoid doing a 2-3 level massive decompression and instrumented fusion. So obviously I'm no longer doing surgery, but I found that to be a very worthwhile approach, and I'd like to see it used more often. I'll bring that book in. Do we still have a library up in the office? Okay, I'll bring it in next week and leave it in the cold room.
Matt, I got a question. I don't know if anyone's speaking right now.
Oh, all you.
Yeah. Sorry if I missed it, but what patient factors are contraindications? And my main one was body habitus. Is that a contraindication?
I obviously haven't done a lot of them, so I'm not as aware. I don't think necessarily, because a lot of times, I mean, a lot of the habitus usually tends to be like anterior central adiposity going through. I mean, unless they got some huge love handles. Dr. Malberg, have you done any on?
Yeah, it's uncomfortable, but it's not a contraindication.
You're just going to be deeper, darker hole, I think, like most of our cases end up being.
Okay, thanks.
Yeah, for males with a large big BMI, it's usually anterior panis, and it falls aside. It was one case we even taped it out of the way. Females are a little more evenly distributed, but on the other hand, it's easier to do dissection. The tissues are just not as resilient. So the instruments are long enough. I never had to turn a patient down because of size. Although after halfway through the case, I wish I had, but
Any other questions? Good.
I guess I got another question. So
Okay.
My big concern would be a viscous injury, renal injury.
Yes.
I guess just because we're not in that world much anymore, how are you monitoring for that? Someone has a lot of pain post-op. What are you looking for?
So the things I've seen as far as actually, I don't in here. So they actually list the percentages in this study pretty well. So they had 3 out of how many patients? 3 out of 1,795 in the pre-SOAS, and 3 out of the 2,300. So it's very, very, very low risk. And then there was 1 case of a ureter injury anterior to psoas, 0 with the Transpsoas. Usually what I've seen is it's not usually caught intra-op, it's usually caught post-op. And these patients, from what I've read, tend to have some sort of abdominal pain, acute abdominal pain, and acute abdomen or something like that. And then generally these patients are getting a CT of the abdomen and pelvis, and then finding out that maybe there was some sort of bowel injury from there. If that happens, then obviously general surgery gets involved and takes it from there. But from what I've seen, you usually don't recognize something like a bowel injury intraoperatively. It's usually a post-op finding. I don't know if you've.
Yeah, actually, it's in the couple of the cases we had where the peritoneum is very thin, and we actually could see some bowels starting to herniate into the operative field, and you have to use a love retractor or retractor to keep it out of the way. there was never any deficit afterward. I think there were 3 cases where I had to keep retracting the bowel, but you really should be able to recognize that. And I think the fact that our training in orthopedics now limits our exposure to general surgery so much that it's hard to distinguish just peritoneal bulging from an actual loop of bowel. So it's, you should be able to see it, and you can retract it. It really makes the case a lot tougher because you have another pair of hands because you need to have someone keep the bowel out of the way. But it can happen. One more quick point about subsidence, and subsidence is usually, if it's not the result of osteoporosis, it's almost always having a cage that's a little too small, doesn't sit on the cortical portion of the end plate, and there's not quite enough. There was an old study when Casey Lee, who was very good spine surgeon, was up in Newark. He was chief of that program there for a while, and he was a big proponent of the PLIFs. And he actually had done a study on the area that you need to prevent subsidence of the bone graft on an end plate, and it was I think it was like 2.4 square centimeters that you needed as a minimum. If you had less than that, you'd always get subsidence. And so if you place the cage, the footprint of the cage is important, and it's hard through an X-lift and an A-lift, and particularly and with the T-lift, as you know, the cages are pretty small, and so the footprint is not enough to prevent subsidence by itself. So you have to supplement it with posterior fixation. It's one of the reasons I'm not a very big fan of a T-lift. The footprint isn't good enough, and the angle that you're putting in, where you're not preventing flexion and you anterior posterior, and you're not preventing lateral flexion. It's biomechanically the wrong angle to put it in, and you can't get a big enough footprint. So that's why I'm much more fond of the X-lift than a T-lift. Hey, Matt, very well done.
Thank you, everyone.